inhibiting her
Mic
ability to
on.
get pregnant.
How would you evaluate for her ovarian reserve?
So things that I could do to evaluate for her reserve would include doing an AMH, and then if it's less than one, if it's
Go
less
ahead.
than
Mic
one,
off.
if it's less than one, then I become concerned about her ovarian reserve.
So why would polyps be of concern? Intracavitary polyps.
Yeah, I would just be looking for any anatomical abnormalities, but I don't think that, having just a single polyp would necessarily cause her inability to get pregnant.
Any other testing that you would do to evaluate for her infertility?
So we said HSG. I would get vitamin levels, mentioned that, hemoglobin A1C, and then just preconception essentially to make sure that she's ready from that standpoint.
Anything else?
Yes. And then the other thing I would discuss with her, as previously mentioned, is if her partner has had any children, because I would want to know, I would want a semen analysis, is about 50% is usually caused from male infertility.
So let's say the patient gives a history of having irregular periods and has a BMI of 55. How would you manage?
So I would initially start with explaining to her that oftentimes having a BMI of greater than 30, being obese, can make it difficult to become pregnant. So even losing 5 to 10% of our weight could assist us with the ability to get pregnant. And then, so I would start with that and encouraging her to have weight loss in order to not only become pregnant, but then have a healthy pregnancy, discuss nutrition with her, exercise.
So let me ask you, so with a BMI of 55, what underlying issue you think is causing her issues of her irregular periods?
Yeah, so if she's having irregular periods with a BMI of 55, the first thing that comes to my brain is that she may have an ovulatory periods. Therefore, she's not releasing an egg every time she's trying to get pregnant. And so that would make it challenging.
So, so how do you diagnose PCOS?
So the way that I diagnose PCOS is in a diagnosis of exclusion. So for someone like herself, I would want to get a prolactin level at 17-OHP to rule out CAH. Once again, we would have already done the hemoglobin A1C, the TSH, and then I could do an ultrasound as well at testosterone level. And depending on if she has hirsutism or not, then I would add a DHEAS.
So what specifically are you looking for on ultrasound?
So what I would be looking for on ultrasound would be polycystic ovaries, which would include having an ovary that's 10 centimeters in size, not in size, but like the actual volume of it, or having 12 or greater follicular cysts measuring 2 to 9 millimeters. And that would give me an indication.
And you said also the size?
Yes, I believe if you have like a size of an ovary that's like 10 milliliters in size, that potentially that's another sign that's consistent with PCOS findings.
So specifically, what criteria has to be met to diagnose PCOS?
Yeah, so the criteria that I would use is Rotterdam criteria. And so you have to have 2 out of the 3 criteria to be met. One is irregular menses or amenorrhea. The second one is the having biochemical or clinical findings consistent with elevated testosterone levels. And then the third would be the ultrasound findings, as previously discussed.
So you said you would check a DHEAS. Why would you do that?
I would do that if she had signs of like having hair on her chest or on her back. And I would be thinking about potentially testosterone level that's being released by the adrenal gland.
So you're looking for more adrenal gland issues. You wouldn't check for DHEA?
Yeah, maybe that's the one, DHEA, the one that's, yes.
So which one is it?
I don't know. In my brain, I'm thinking DHEAS. That's what I'm thinking, but.
Okay.
I could be, yeah.
So how is metabolic syndrome diagnosed?
Metabolic syndrome is, there are, I believe, 5 different criteria, and you have to meet 3 out of the 5. And one would be a systolic blood pressure of 130 or diastolic of 85. The second would be a waist circumference of 35 inches or greater. Then you could have a fasting level blood sugars of 100 or greater, HDL less than 50, and triglycerides greater than 150.
And so what is the implication of metabolic syndrome?
So when I think of someone meeting the criteria for metabolic syndrome, I'm concerned for them being at a higher risk for cardiovascular disease.
So how do you classify obesity?
Classify obesity. So if you have class 1 would be 30 to 34.9. Class 2 would be 35 to 39.9, and class 3 would be 40 or greater.
And who qualifies for bariatric surgery?
Patients that qualify for bariatric surgery would be a patient that has a BMI of 35 or greater with comorbidities such as diabetes or cardiovascular diseases, or a BMI of greater than or equal to 40.
So you're telling me that this patient with a BMI of 55, you would want her to lose some weight before you would assist her in trying to get pregnant. Am I correct?
Yes, and she would be a great candidate for bariatric surgery.
So the patient demands to be started on a medication to get pregnant. How would you handle the situation?
So I would explain to her that I respect the fact that she wants to become pregnant, and because this is the first time that I'm meeting her, that I would like us to work together to get a plan in motion so that she could, one, have a healthy pregnancy, stay healthy herself, so that she could also deliver a healthy baby and decrease her chances of having spontaneous abortions and stillbirths in the future.
All righty, what'd you think?
Boof, my heart is beating like the entire time.
I think you did very, very nicely. DHES is adrenal gland only.
Yeah, okay, DHES.
Okay.
Yeah,
So DHEA is the ovary.
okay.
So if you're concerned there's a mass in the adrenal gland or something, you do the DHES, EAS.
Okay.
Okay. But I can't think of anything that you said out of turn. I mean, I'm trying to think everything. You're correct in your metabolic syndrome, in your PCOS, your obesity classification. I liked your answer and how the patient would handle the situation, how you handle her, demanding. You know how patients can be very demanding.
Yes, absolutely.
I like that you brought in, drug use. I felt like I prompted you a smidge for the semen analysis.
Yes, you did, and
Bit.
definitely, you did, and I
You had it,
definitely.
you had it. And, sometimes they do that in the exam, or many times they don't. But I felt that you knew it just because you were going at a good pace. Maybe a little bit fast, but I knew you knew the material.
Sorry, yeah, I was, my heart was beating, so I started to talk fast.
I mean, I can't say I can add any other information. I mean, I think everything you said was correct. I'm looking at my notes, and I think we're spot on.
Okay, awesome. Thank you so much.
All right, very good job. Okay.
Thank you.
All righty. So does anybody have any questions in regards to this structured case? Please put it in the question box, or if you want to raise your hand.
Mic on.
I don't see anybody. Sarah has her hand up. I'm going to go to Sarah here real quick. She's self-muted.
Sorry,
Do you have a question, Sarah?
No, sorry.
Okay. You are on the list, but later on, okay?
Okay,
So stick around, okay?
sure.
Trying to see if anybody has any questions in regards to this one. I don't see it. So the next one's going to be a lengthy one. So I'm going to pick actually 2 people. I know Jasmine is on the call, so let me go find her. I see Corinne has her hand up. Do you
Yeah,
have a question, Corinne? Yep.
more like a not a question about the information, but
Yep.
if they have to prompt you for something, you know, because obviously in a test taking situation, you know, you might accidentally forget something. Does that like take off point or
I don't think so. I'm not privy to how they score, but I don't
Okay.
think so.
okay?
I don't think so. But remember, they could also pull that anything else, and they're lying to you, or they're psyching you out to freak you out. In her
Right.
case, I knew she was forgetting something.
Okay.
And sometimes they'll say that to freak you out, and I'll say that sometimes, and sometimes you have to say, no, I'm sure that's my answer.
Okay. Thank you.
Okay, and you're also on my list, but later on.
Okay.
It all depends if I can't find anybody from above. Let's put it that way. Okay,
Sounds good.
all right, all right. So Yasmin, I'm going in your direction here. I know I saw you. I see a question here. Hold on. Melody is asking, do you have to order labs if they have clinical signs of hirsutism? No, you do not. I think bariatrics can be offered at BMI of 30 and 27 with comorbidity now. You know, it all depends who you read, but what I reviewed would be after 35, because a BMI of 30 is not that bad. I mean, because a lot of bad things can happen after bariatric surgery with complications. So, yeah. Genevieve, we're going to talk about that a little bit later, okay? But for Stephanie, I think more of an issue would be greater than 35 to get bariatric surgeries, in my opinion, at 27 or 30. I mean, you could lose some weight there. I mean, it gets to a point you may get very, very heavy and you need assistance, but you should be able to lose some weight at the BMI of 30. That's just my opinion. But the last time I checked, which was a few months ago, it was still up to date, clearly said above 35. Okay, Jasmine, you're there? Says you're self-muted.
Okay, I think I just unmuted.
You got it. You got it. Okay.
Okay.
So there you are, Yasmin. And then Jennifer. Are you there?
Yes.
Are you there, Jennifer? So I'm going to do a twofer because it's going to be a long case.
Okay.
So Jasmine will get the first two and you'll get the second two roughly. I'll let you know when one will go and when the other. Okay? I'll keep you guys both on the line. Okay? So you'll be answering the first ones first, Yasmin. Okay?
Okay.
All right. Let's say the previous patient presents 8 months later, status post-bariatric surgery with a BMI of 50 and 8 weeks pregnant. How would you counsel the patient about her pregnancy, labor, and delivery?
So starting off, just in regards to being 8 months out from the bariatric surgery, it is generally recommended that these patients wait about 12 to 24 months before pregnancy due to the attempt to try to prevent baby being exposed to the rapid weight loss that does occur within that first 1 to 2 years. So we would have a discussion about that. But of course, at this point now she's pregnant. So it's kind of a moot point, if you will. But then moving on or expounding from that, in regards to her BMI, we would have a discussion about, from a maternal standpoint, how obesity and pregnancy does increase your risk of gestational diabetes. It does increase the risk of preeclampsia. As far as labor is concerned, it can increase the risk of labor dystocia and cesarean section. And with a BMI over 50, there is an increased risk of postoperative wound infection as far as the delivery or postoperative standpoint if she had to be delivered via cesarean section. And then going on in regards to fetal risk in regards to the pregnancy, there is an increased risk that when it comes to targeted or the anatomy ultrasound, there may be difficulty in viewing the complete anatomy. So there could be structural or fetal anomalies that may go missed. There is also a potential for fetal loss or fetal demise, as well as these babies also being on the larger side as well.
Anything else that you'd be concerned about because of her history of her surgery?
And then the other thing that you also have to counsel these patients on with bariatric surgery is that usually for me, whenever I have somebody who has had bariatric surgery, if they're not already on a multivitamin, because they will have potential deficiencies in iron, vitamin D, protein, all of these things that are normally found within certain parts or absorbed in certain parts of the gut, they can have deficiencies in if they're not already on some kind of multivitamin or supplement. And then I also prefer to have the surgeon who performed their bariatric surgery in on the beginning of the pregnancy, just in the event that during the pregnancy there are any like GI or abdominal concerns in regards to the surgery.
Now, would your concerns change dependent on the type of procedure she had done?
Yes, they would.
In what way?
So generally with patients who have had like some kind of banding procedure, you can have potential for migration or movement of the band during pregnancy. And so that would be something that would differ from somebody, of course, who had a non-banding procedure, in which case, again, you'd be worried about potential electrolyte, deficiencies as far as supplements.
Anything else?
I guess if she's only 8 months out, they could potentially, or you would potentially be concerned about there being some kind of breakdown as far as the surgery itself.
So what diagnostic tests would you order now and throughout the pregnancy, and why?
So generally with these patients, again, kind of going back to the potential for the deficiencies, I tend to order on that first visit a CMP, vitamin D, iron levels, and then of course all of the other standard prenatal labs as well. But I tend to repeat the like the vitamin D, iron, and those at least every trimester, just to make sure that we aren't missing any deficiencies that could occur throughout the pregnancy. And then as far as other tests, towards the beginning at the 8-week mark, she's still a little too early for like her cell-free DNA, so on and so forth. But those tend to be the general ones that each trimester I will at least order in order to make sure that we're keeping on top of any deficiencies.
Now, in regards to the deficiencies, how would you replenish some of them? Are there any concerns?
The biggest concern is with the vitamin D, because it is a fat-soluble vitamin, and so it has to be absorbed by the liver or broken down by the liver. And so you can potentially have side effects if there is too many fat-soluble vitamins that build up in the body.
Anything else you'd be worried about nutritional wise?
There's also iron, calcium.
So would you give all that orally or in a different route of administration?
I give it all orally.
Okay, even the iron?
The iron, I generally start off with doing orally, but I do make the patient aware that there's a potential that she may not adequately absorb it. And so in those patients, when we do repeat CBCs throughout the pregnancy, if there is evidence of anemia, we start off first with doing a workup to determine whether it's due to the folate, vitamin B12, or an iron deficiency. And then from there, assist our heme-onc physicians in regards to doing IV iron therapy for these patients.
So what discussion or education would you give the patient in regards to her weight gain in the pregnancy?
So generally in patients who are over a BMI of 30, the recommendation is no more than 11 to 20 pounds within the pregnancy. There is some literature, which off the top of my head, I cannot recall, that did make suggestions different for patients who are over a BMI of 40, but I can't recall it off the top of my head right now. So I do at least know that over 30, it's 11 to 20 pounds over the course of the entire pregnancy.
Any other testing that you would do? I'm talking about for the entire pregnancy. I know you mentioned she's at higher risk for certain disease processes in the pregnancy. Anything that you would do in order to evaluate for those?
Yes, ma'am. And so generally for patients, of course, between about 18, 22 weeks, leaning more towards the 22-week side, we would attempt to try to do a targeted anatomy ultrasound. We also employ the assistance of our maternal fetal specialist, and my group, along with the specialist, starting at 32 weeks for these patients. Once they get over a BMI of 40, we start doing twice weekly antenatal testing along with serial growth scans every 4 weeks.
When would you start the antenatal testing?
We start at 32 weeks.
32 weeks. Anything else that you would do as a baseline or to check? Because she could be at higher risk for.
Yes, ma'am. And we also do an early glucose screen in the beginning of the pregnancy, and that one is normal, repeated between the 26 to 28 week mark. And then we also get baseline preeclampsia labs on these patients, as well as a protein to creatinine ratio from the urine. And then we also consider starting these patients on a low dose aspirin at the 12-week mark, just to further assist with decreasing the potential risk of developing preeclampsia.
Would she be able to tolerate the routine glucola?
So I'll say it depends, because I have had some patients who have been able to tolerate it and then others not so much. But if she were somebody who was not able to tolerate it or experienced a dumping syndrome after the glucola was performed, you do have the alternative option for doing paneling for at least 2 weeks to kind of see where blood sugars are running.
Would there be any consideration for induction of labor?
Yes, for these patients, once they start to get over a BMI of 40, just due to that increased risk for IUFD, we do consider inducing their labor at 39 or sooner if there's subsequent maternal or fetal indications that develop throughout the pregnancy.
Anything you would do to evaluate her cardiac system in any way, shape, or form?
Yes, ma'am. EKG and an echo, we usually do that as well, along with the baseline blood work at the beginning of the pregnancy.
Okay, very good. Now we're going to move on to Jennifer. Stay on the line, Yasmin, and we'll give you feedback.
Okay.
Okay, so let's say, so Jennifer, you're there?
Yes, I'm here.
Let's say the patient during her labor is making slow progress. How would you manage this situation?
So in obese patients, it's not uncommon for their labor to progress more slowly. So you want to give them more time to progress in most cases, as long as there's no other indication to deliver sooner and the baby's tolerating labor.
So is there any cutoffs, any things that you would do in order to evaluate her progress?
So you could manage it similarly to other patients in making sure that her contractions are adequate by placing an IUPC. And then, you know, I typically, when managing patients in general, I'm using the guidelines to help prevent our primary C-sections.
So what guidelines are those?
So if you're not progressing in latent labor, you want to give up to 24 hours with rupture and on Pitocin before you would consider it failure to progress in labor. And in active labor, 4 hours with rupture on Pitocin with adequate contractions, or 6 hours with inadequate contractions before before considering it, you know, failed labor.
What do you mean by adequate contractions?
So this would be determined with the IUPC in place, making sure that you're having the appropriate amount of Montevideo units within a 10-minute period. So you want that to be over 200.
Over what time frame?
10 minutes.
But is there a time frame, like how long she would have the adequate contractions?
So you would want her to be having adequate contractions throughout the time. If she's having continuous adequate contractions, then
For the, you said the full 4 hours?
correct.
But then if it's inadequate,
You can,
she's arrested in 6 hours. Is that what you told me?
yes.
So going back to failed induction, anything else that needs to be addressed in a failed induction? You said she had to be on Pitocin for 24 hours?
With AROM. or rupture of membrane.
And nothing else? So let's say the patient, she's been ruptured for over 24 hours and has been on Pitocin and has made no change, and she's 2 centimeters. But she wants to continue the induction.
So,
How would you counsel the patient?
well, if she's 2 centimeters, you know, you can consider, I typically would consider doing other things at the beginning of labor for ripening. You know, I don't know if at this point in her labor she would have gotten Cytotec. I'm assuming you're past that point. You can consider additional of a cervical ripening balloon, but you typically wouldn't do that when they've been ruptured.
She's been on 24 hours of Pitocin. What other options does the patient have? And she doesn't want to have a C-section, not yet.
So,
I guess, is it a hard pass rule? She has to be
no,
delivered.
no, not as long as she's doing okay. There's no signs of infection. The patient is, or the tracing is looking good, and the baby is okay. You can consider doing a Pitocin break. There's some evidence that giving things like Tums for calcium to help reset the Pitocin receptors can be helpful in these patients, and then restarting the Pitocin. Because after
in that, let's say her patient has a 2 centimeter dilated, 40% effaced, she's -2 station, been ruptured for 24 hours. How would you restart that Pitocin?
So I would start, it depends how long the Pitocin's off. If it's been off for about 30 minutes, normally start at half of whatever dose she was on before, but you could turn it off and restart from the beginning. Typically, whenever I'm titrating the Pitocin, I start at 4 and go up by 4 to up to 30.
So you would go by 4s all the way to 30 in this type of situation, even though she has an unfavorable Bishop score.
Well, if she's been ruptured, you wouldn't ideally want to put a balloon in, but you could go back and start over with Cytotec if you're in that position.
And that would be vaginal or oral?
Buccal is how I prefer to do it.
And what's your dosing there?
Do a loading dose with 50 and then 25 every 4 hours, up to 6 doses.
Anything else you could offer the patient?
You could also do a Cervidil instead, but again, at this point, I prefer to be doing things by mouth rather than vaginally to decrease the risk of infection since she's been ruptured for so long.
So let's say the patient has an arrest of her labor and requires a cesarean delivery. What would you do for this patient secondary to her BMI? Preoperatively, intraoperatively, postoperatively?
So with my patients who have a BMI of 50, really over 40, I have them intrapartum have a visit with anesthesia to discuss risk surrounding delivery. Anesthesia also sees them once they're on the floor and would have already seen her if she had an epidural. Intraoperatively, talk to them about risk of difficulty with the procedure for her increase in adipose tissue. We have something called a Traxi drape that helps elevate the pannus depending on how her body weight is distributed. In some cases, in these patients, I would consider doing like a sunrise incision to decrease risk of infection with a fan and seal.
So what do you mean by a sunrise incision?
So an incision above the umbilicus with retracting the pannus downward to get to the lower uterine segment through that incision. That area is more easily accessible to the patient and easier to take care of. versus underneath the pannus, where it's more likely to be moist, harder to see, and more difficult to take care of.
So when you do
Mic off.
sunrise incision, how would you deliver the infant?
So very similarly to how you would with phantom steel incision, when the pannus is pulled down, the area that you're accessing on the uterus is still the lower uterine segment. So I'd still do a low transverse incision and deliver the infant.
So you won't have a difficulty getting to the lower uterine segment?
Typically not if the pannus is retracted inferiorly enough. So it's nice to have additional hands in the OR to be able to do that. Sometimes the angle can be a little bit more anterior to the patient's body and can make the delivery of the head a little more difficult. In some cases, vacuum can help with that angle just to elevate the head if necessary, but most cases it's not as difficult.
Let me just go back to preoperatively. Anything else you would do in this patient's situation before you did her procedure?
Yep. So I would talk to her about the procedure, counsel her on the risk and benefits, talk to her about risk of bleeding, infection, damage to surrounding tissues. Talk to her about antibiotics because she's been laboring and ruptured. With these patients, I give Ancef and azithromycin.
What's the dosing?
Depending on what her actual kilograms are, I would suspect 3 grams if she was over 120 kgs. But if she happened to be lower than that, it would be 2 grams of Ancef and then 500 milligrams of azithromycin.
Anything else you want to have preoperatively coordinated before you do your procedure?
Want to make sure I had availability for uterotonics if she'd been laboring this long. She has increased risk of postpartum hemorrhage. At our facility, we have all of that available in a cart.
Anything else?
Not that I can think of at this time.
How about intraoperatively? So you've discussed how you would make your incision. What else would you do intraoperatively?
I otherwise typically perform the procedure the same way as I would with anyone else. Again, with making sure that I'm managing the patient's pannus to be able to get access, make sure I have enough, assistance in the OR to be able to have visualization and deliver the fetus. Whenever I'm closing, I would make sure that I'm closing the subcutaneous tissue appropriately to decrease risk of like seroma formation or infection.
So how would you do that?
I typically do it in multiple layers with absorbable suture.
Would you do anything specific for her fascia?
A lot of times in patients with larger BMI, I'll use PDS as opposed to Vicryl.
Why would you do that?
Because it increases the strength of the closure and decreases their risk of dehiscence.
Anything that you would do postoperatively?
Talk to the patient in detail about increased risk of postoperative wound infection and making sure that they're taking care of their incision site really well. I see these patients back in the office within the first 1 to 2 weeks to check in and make sure that their incision's healing well as well.
Anything else postoperatively?
Definitely would consider doing Lovenox depending on the patient's mobility. Definitely in the hospital, and then I discussed with the patients about potentially going home on that for up to 6 weeks postpartum.
Alrighty, what do you guys think? I'm gonna go to, who's laughing there? I'm gonna go to Yasmin first.
Jasmine.
I'm going to Yasmin first. I really like the listing of things you told me. In regards to the diagnostic tests, I felt that I had to tease out a little bit, but you had
Yeah.
mentioned a lot of that stuff. So don't forget what you said, right?
Yeah.
And because you're the first question, I thought you hit it out of the park, but I did feel I had to kind of tease some things out. What you want to be doing, and of course, this is where practice comes into play. I call it diarrhea of the mouth. You just keep talking and talking, but the more practice you get, you're going to be more tailored in what you say, and it's going to get to a point they're going to cut you off.
Right.
Because
Right.
they
Yeah.
know you know that material.
Yeah, and I pretty much agree. I also had made some notes too, and I definitely felt like I would get started, but then there was a lot more prompting that subsequently had to be done too. So like you said, I think it's just a matter of continuing with these practice sessions and then just getting to a
Yes.
point where it just rolls right off of my tongue. I do
Right,
agree.
because you were good in your evaluation. Just as there's several methods of doing the bariatric surgery. If it was a lap band, that you can release. So then that way you wouldn't have to worry about issues with her stomach or anything like that, because they release that restriction. But anything else, like the sleeve gastrectomy, the Rowan Y, those are of issue. And I like the way you said, I would start her off on oral iron. However, if it's not beneficial, then I would focus on the IV. And so the same thing with your B12 and those type of things. Your weight gain was appropriate too. The glucola, a lot of them, they get that dumping syndrome, but I like how you answered that. And don't forget your baseline PIH. You brought in the aspirin. I had to bring out, don't forget about the cardiac aspect in these really large women.
Yes, ma'am.
And of course, induction, because you really definitely don't want them to go beyond their due date. Definitely do not want to do that.
Right.
Okay, but other than that little bit of prompting, I thought you did well.
Thank you.
Okay. All right. Very good. Jennifer, are you there? Like, I'm able to unmute you and then you get muted again. You're there?
Okay. Yes, I was having that issue.
In regards to what? I'm sorry.
The muting, sorry. It just kept
Okay.
muting
Got
and
it.
muting.
Yeah, I don't know what the computer's doing. Yeah, I think you did well in your answering of things. I can see an MFM being a little bit more tougher, because I don't know, because some people would be of the theory that she has a poor Bishop score, would like low dose PIT be more beneficial. Some units, and I'm not saying what you said was wrong, I'm just bringing things up. I don't know if going up by 4s all the way to 30 is going to be, because you really don't need a lot of contractions. You just need the ripening. Am I making sense? And contractions does not lead to ripening.
Sure.
You brought in the failed induction. I didn't. You know what I'm saying? So then I asked you questions about it. Does that make sense?
Sure.
I'm not saying what you said was wrong, but some people would be of that theory. Some units, their protocol, you cannot put a balloon in a ruptured patient.
Right.
Because I believe the Cook catheter data, we don't say data on this exam or literature, those people were precluded. Those people were precluded. So that's why a lot of units don't allow them. Anytime I've done that sunrise incision, I didn't know it was called sunrise. They always have to deliver the lady breech, because you can't even get to the lower uterine segment. Because they're so big. But the last time I saw it was on a BMI of 75. So
yes, I had a lot of practice in residency. I don't have many patients who are really over 50, 55.
Right.
I don't really do it very often in my current practice.
Right. Like the last one I saw, I was like, whoa, I was assisting. I went, oh my goodness. They was bleeding all over the place. It was a BMI of 75. Traxi wouldn't have held anything in any direction. Yeah, don't forget your ANSEF, the increased amount of the dosing, your exposure. I brought in the fascial closure, and I liked your answer. Don't forget your VTE prophylaxis. That's very important. I'm trying to think what else. No, I think good job. Any questions there?
No, I just felt like you were wanting something else for the induction, which I'm sure I will feel like on the test day that I'm not giving them what they want, but I just have to
And they
give
make you feel that way. They make you feel that way. The only question I had was kind of the Pitocin, when she was 2 centimeters. That's the question I had, which some people would disagree. That's where the art of obstetrics comes into play. But you didn't say anything out of turn. And they'll go, "Are you sure? You're sure about that?" You didn't say. I was just trying to psych you out on that one, on some of that. Okay.
Thank you.
All right. No, good job. So both Yasmin and Jennifer did a great job here. Anybody have any questions about this case? Put it on in the question box. Okay, Bobby. Bobby's an MFM. What did I say wrong? Would it be wrong to say you would just do a fanny stool? No, I wouldn't, Bobby. I don't see any problems with that. I did a BMI of 60. I did a fanny steal this past week. Do you do VTE prophylaxis for 6 weeks post-op with severe obesity or just while in the hospital? You know, that's an interesting one, Tiffany. A lot of people say it's just in the hospital, but some people are of the opinion that if you're going to start the prophylaxis, why don't you just continue it? Bobby, do you have any perspective as an MFM? Ijoma says, did you say you wouldn't use a Cook catheter? She's ruptured. I personally have, but according to many labor floor units, it's not part of their protocol because the Cook, to my understanding, Cook catheter data precluded anybody that was ruptured. So that's why a lot of units say you cannot. Of course, sometimes it's the discretion of the physician, so you would have to get special permission. Sarah's asking, okay to use Vicodin and fascia for primary cesarean in an obese patient? Yes, it could be because it is her first case. I'm not saying anything wrong one way or another, as long as you defend what you did. Can you review the vitamins for people with bariatric surgery? It would be checking your iron, folate, vitamin B12, calcium, vitamin D. Okay, Shikara, you would let them go past 24 hours ruptured on Pitocin. This is for Jill. As long as everything's looking fine, there's no set rule that says you have to be delivered by, to my understanding, that you have to be delivered by a certain time frame after ROM. To my understanding, if the patient's okay to continue, theoretically you could add a Foley bub. Correct. My unit, they realized the game we were playing, and they say Foley bub as well. If they're ruptured, you got to get special permission because the Foley bub didn't get any data or studies done in the sense of if you're ruptured or not. It's not like the Cook. Definitely for you, I would do weight-based prophylaxis. In this case, I believe she would be 40 twice a day or 60 twice a day. I would have to check when you calculate. You know, I'm not quite sure, but definitely I don't think it'll be 40 once a day. She'll need a little bit more. Would we start low dose aspirin based on her BMI, or if she has another moderate risk factor too? Some people are of the opinion because of her BMI, you would. I do know ACOG has specific factors, and then you add those together, and then it says those people definitely should be on low dose aspirin. But I know just because of the patient's weight, some people would automatically start her on that. Tiffany saying, is it wrong to have shared decision making and counsel patient for C-section of 24 hours? Do you really need to do more ripening? No, it would be up to the patient. If the patient, she has met the 24-hour rule, she can have a C-section if she desires to go that route. But on the flip side, Tiffany, you may have patients who do not want to have a C-section, not yet. I always say, if the fetal heart rate tracing is doing okay, no signs of infection, we can continue. Because if the square peg is not going to fit in the round hole, at some point, the tracing is going to not be good. Right? There's patients that just don't want that C-section, and next thing you know, once they hit that active phase, they go real quick. But you had to get her to that after that ripening to that active phase. So there's nothing wrong with that, Tiffany. Nothing wrong. It could go either way. Have I heard of giving patients flagyl for obese patients post-operatively to help decrease risk of infection? I have not heard that, Yojima. I'm not sure about that. I do not know. I can't attest to that, to be honest with you. So apologies on that. Is obesity an indication for induction? I thought ACOG does not make this recommendation. You don't want to go beyond the patient's EDD. For AMA or obesity to my understanding, especially with a BMI of 50. Okay, I would have to refer the specifics, but to my understanding, I remember reading that in the practice bulletin, because BMI 50 is a significant risk. I mean, her risk of IUD is high, still low, but higher than the general population by a good amount. Especially, there was a big study that came out of, again, you don't say studies. If you're African American, a BMI of greater than 40, her risk it was almost like 5 times fold, even though it's still low, 5 times more than a regular patient. So that's a significant. I mean, can you imagine if you you deliver a lady at 40 plus weeks, and if she had been delivered at 40, the baby would have been alive if it was fetal demise. That would be tragic. Practice bulletin says pre-op antibiotics in obese women still have therapeutic levels at 2 grams per ANSEF. If I'm not mistaken, I know I've read in the practice bulletin, Genevieve, that if your BMI is elevated, your weight is more than 120 kilograms, the recommendation is 3 grams pre-op. So I can't attest to what you've read, but that's what I understand. Bobby, can you write in, have we said anything out of turn? Anything that you would make different as an MFM? Not at all. So it sounds good. All right. So Bobby's giving us the thumbs up. So I don't know what to tell you on that one, Catherine, but to my understanding, greater than 120 kilograms, it should be 3 grams for prophylaxis, or a greater than 1500 cc blood loss, or I believe a longer than, 3-hour surgery, if I'm not mistaken, would be all indications to give another dose. Okay. All righty. Okay, I have Jill here. From practice bulletin on obesity, maternal obesity alone is not an indication for induction of labor. However, obese women are at increased risk of prolonged pregnancy and have an increased rate of labor induction. I'd have to review that. I'm so sorry. Jill, I cannot comment. Okay. And then Bobby, what I said is when you redose, correct? That's what I remember from the practice bulletin. 4 hours. My apologies, not 3 hours, 4 hours. Apologies. It's 50. I know it's 1500 cc's blood loss, and then 4 hours according to Bobby. So Jill, I'm sorry I can't add more information, but I know you're definitely at risk for fetal demise when you're obese like that. Okay, so I'm going to go on to the next case here. Apologies, Jill. I'd have to review that. Okay, sorry. Ashley, we're going in your direction. It says you're self-muted. Are you there, Ashley? There you go. Are you there, Ashley?
I am, yes.
Okay, give me a second. Chihiro, you would be coming up next. I'm gonna see if you're here so you can stay on the call. It doesn't look like Chihiro's here, but we'll check again. And if it's not Chihiro, the next person will be Elizabeth. Okay, you'll be the next person on the hot seat. Okay, so you're there with me, Ashley?
Yes.
Okay. You're a generalist?
No, I'm
you're a guy. You're a guy.
Yeah.
You'll be fine. You'll be fine with this one. Okay, so let's say the initial patient presents 28 months later with a BMI of 32 due to significant lifestyle modifications, but still unable to conceive with a negative infertility workup. Discuss your preconceptual counseling visit.
So at this point, I know that she's conceived in the past, and she's got a negative infertility workup.
No, she's a para zero. She's a para zero.
Oh, I see. So
Yeah,
we didn't.
yeah.
Second piece.
Yeah. She never
Got
got
it.
pregnant. Okay.
So then what I would talk to her about are other reasons why, infertility can happen. So if the infertility workup was negative for the female, I would definitely check the male factor. And if that was also negative, a lot of this can be idiopathic. And I would discuss with her potential for ovulation induction,
So
or
let's hold on a second. Can you discuss for me her preconceptual counseling visit? Your preconceptual. She's saying, I want to get pregnant. Is there anything specific that you would evaluate before helping her conceive?
so preconceptually, sorry, has she had the bariatric surgery or not?
No, she's the regular patient. She lost weight.
She
On
just
her
lost
own,
weight.
and her BMI went to 32.
Okay, so I would congratulate her on her weight loss. I would encourage to continue her diet and exercise. Make sure that she's still taking in proper vitamins. At this point, I would recommend to her to start taking a multivitamin and with folic acid supplementation. I would also discuss with her possible carrier, like expanded carrier screening if she's interested in that. That's where I would start.
Anything else that you'd be concerned about to make sure she's optimally ready to get pregnant?
I would also assess her cardiac status, so the EKG and echocardiogram. Just at baseline, I would make sure that her hemoglobin A1C is doing fine. Pretty much primary care indications at that point.
How would you manage the patient?
So at this point, I would then start talking about potential for ovulation induction, especially if I thought that she had a aspect of this that was anovulation. And that I could test with a progesterone level, like a 21-day progesterone level, to see if she was ovulating. But I would.
Any other tests? Is there anything else you could do to assess for that?
There's also like a basal body temperature that I could talk to her about doing. Those are what's coming to mind right now.
So you said ovulation induction. Anything else that you would need to know before you would offer that to the patient?
I mean, I'm seeing negative infertility workup, so I'm assuming that we've done all of the labs for like thyroid, prolactin, checked her uterine cavity, checked her tubes with an HSG, checked for male factor infertility.
So you feel confident at this point we could offer her the ovulation induction?
Yes.
So discuss your ovulation induction protocol.
So if I thought that this patient was more of a PCOS picture, again, matching the Rotterdam criteria that was already explained, then I would recommend letrozole. And that's usually on days 5 through 7 of the cycle. Or I could recommend Clomid. And I usually...
So, let me interject here a second. What is the mechanism of action of letrozole?
Oof. I would have to look that up.
And then now, what is the mechanism of action of Clomid?
I would also have to look that up.
So what makes you decide if you're going to do letrozole versus Clomid?
There's literature that says that letrozole is...
Oh, what type of literature? Can you mention it?
No, to my knowledge, letrozole has a higher live birth rate than Clomid in PCOS patients.
So you would offer it in a PCOS type of patient?
Yes.
Okay. So can you go specifically into the protocol for me? So what dosing would you give the patient?
I'm not sure what dosing, but I think it's on days 5 through 7. And then you do it for 3 cycles. And if she has not conceived at that point, then I would refer to REI. With the Clomid,
you would give her, let's hold on for letrozole first. So you would give her the 1 dose, and if she doesn't ovulate or get pregnant that first cycle, you just refer her to REI.
I would do 3 cycles.
Okay.
And then if she didn't get pregnant with that, then I would refer to REI.
So how do you know if the induction's helping? the ovulation induction's helping, what would you do? What would you evaluate?
I would evaluate that she is ovulating, and so that's the progesterone day 21.
And is there anything else that she can do at home to
The
evaluate that?
basal body temperature at home.
Anything else?
There's a LH surge that happens.
So how do you test for that?
So she could
At
do
At
just
home?
like a urine LH. There's over the counter kits that she can purchase, and like 5 to 12 days after the last Clomid or letrozole dose, she can take that LH test at home.
So what do you instruct the patient to do at home in regards to having relations?
So I would recommend that she have relations usually. So if she starts on day 5 and goes through day 7, then starting like day 6 and go through starts on day 10 and goes through day 14 every other day at home.
And so how would you do your Clomid?
The Clomid, I usually start with 50 milligrams daily for 5 days. And then I can increase that every cycle if she hasn't gotten pregnant. And that would just be, again, for 3 cycles for a maximum of 100 milligrams.
So you start her, you said at 50. If she doesn't ovulate, you'll increase her to 100.
Yes.
If she doesn't ovulate, then what would you do?
I personally do another 100 cycle, but you can go up to 150 per the FDA.
And what days of the cycle would you instruct her to take the Clomid?
That's the 5th day for 5 days.
The 5th, what do you mean by the 5th day?
The 5th day of the cycle.
So you start on day 5, so day 5 to 9?
Yes, it's when she starts spontaneous bleeding, then the 5th day after that.
You would start the Clomid. For how many
Yes.
days? So do
For
you change
5.
your protocol depending it's letrozole versus Clomid, or no?
I don't think so. I'm not 100% on the letrozole, but the Clomid is days 5 through 9.
So when would you refer to the REI specialist?
So I would usually do 3 cycles of either Clomid or letrozole, and if she hasn't conceived at that time, then I personally would refer.
Alrighty, what'd you think?
I need to look up the dosing.
Yeah, but you did pretty good for a Eurogyne.
Thank you.
Yeah. Don't forget about your, I don't recall you saying anything about immunizations or titers.
Okay.
Am I correct?
I did not say anything.
Okay, so that's what I was trying to get at. So yeah, because you want to make, God forbid, she gets varicella when she's pregnant. She could have, you know what I'm saying?
Right.
You said to start her prenatal vitamin, optimize management of any medical problems. So you said that stuff. So letrozole blocks conversion of androgen to estrogen. Clomid inhibits normal estrogenic negative feedback, which results in an increase in pulsatile GnRH secretion from the hypothalamus and subsequent FSH-LH release. Okay?
Okay.
Now, letrozole is not FDA approved, and you have to let the patient know that. Last I checked, it still had not been FDA approved. But they're saying, because before the recommendation or the thought process is you offer it in anybody with a BMI, with PCOS with a BMI of greater than 30. Now, letrozole can be used at any BMI. Okay?
Okay.
the rate of live birth rate, according to a study, of course, you don't say study, with PCOS and a BMI of 30, of greater than 30, live birth rate with letrozole was 20%, and with Clomid, it was 10%. Okay. So you can begin on day 3 or day 5 of your cycle. I have spoken to some REI guys. They say the earlier you begin in the cycle, the more success. This is just me talking to them. So it could go from day 3 to day 5 for, 5 days. So either day 5 to 9 or 3 to 7.
Okay.
Right.
And that's for letrozole and Clomid?
Yes, but they believe the earlier is for letrozole.
Okay.
But again, I'm not an REI. So you begin on the 5th day of the cycle, following either spontaneous or induced bleeding. Once ovulation is achieved, the same dose should be continued for 4 to 6 cycles. You should have relations every other day for 1 week, beginning 5 days after the last Clomid is taken. The response to treatment should be monitored. LH surge is 5 to 12 days after the Clomid is taken. And ovulation usually occurs 14 to 26 hours after the urinary LH surge. 21-day progesterone of greater than 3 nanograms per milliliter indicates ovulation. Ideal would be greater than 10. Clomid dosing is 50 milligrams, 100 milligrams, 150 milligrams. That's the max. So if you go all the way to 150 milligrams, if she doesn't ovulate, at that point, I would refer to an REI subspecialist. Letrozole, again, they prefer earlier, day 3 to day 7. Okay, letrozole is 2.5 milligrams, 5 milligrams, 7.5 milligrams. So what I read in up to date, you can start the Clomid on either cycle day 3, 4, or 5, but letrozole, they were more firm on starting on day 3. Okay. So questions on that? Did I miss anything? Did I lose you?
No, I'm still here.
Ashley? Okay,
Yeah.
questions.
I don't have any.
I mean, I think you did good.
Thank
For
you.
your guy. I mean, if somebody had asked me that, I'd be like, what? Let me see if anybody has any questions here. Let me look. So, oh, I have an REI fellow here, Victoria. Okay, so REI fellow, we generally start cycle day 3 to 7. Agree with earlier start to help with follicular recruitment for both, just like what I told you with one REI that I spoke to. So there you are, Ashley.
So
Can
both.
letrozole be used first line for non-PCOS patients? To my understanding, yes, you can. Can you use Femora in patients who do not have PCOS? Lauren, I that's beyond the scope of my knowledge. I mean, letrozole, I mean, it's the same, I mean, Femora, I mean, is it also, I mean, I'm blanking here. It's in the same class of drug, but I don't know, to be honest with you, Lauren. I'm not a PCOS. Generally, this is what Victoria's saying. Generally, since it's off-label use, you would use it predominantly for high BMI patients, greater than 30 BMI, or PCOS patients. That's what Victoria is saying. Sorry, I don't know that, Lauren. I'm just a lowly generalist. Question from Bobby. In a non-PCOS patient, can you use either letrozole or is letrozole preferred? Bobby, because of the higher live birth rate, letrozole is preferred now at any BMI. How many cycles did you continue before changing dosing? If you don't have, okay, I wasn't clear there, Jennifer. My apologies. If you ovulate, you stay at that one dose. If it's 50 milligrams of Clomid, for example, you stay at that dose, and you could do up to 6 cycles. But realistically, if nothing's happening by cycle day 4, fourth cycle, I would refer to REI. Especially if she's young, you could probably get away with it. But if she's older, she's 31 or something, I'd be moving her to the REI. That's if she's had no ovulation whatsoever. So, but once she ovulates, if she does, you stay at that dose, if it's 50 or if it's 100. So I'm sorry if I wasn't clear with that, Jennifer, my apologies. Okay. So if we do not offer ovulation induction subspecialty, is it reasonable to say we would refer to REI to discuss start ovulation induction. Catherine, unfortunately, this is considered a basic generalist topic. So and I know in a lot of clinics, you have a specialist that takes care of anybody who has infertility issues, but you should know the basic, you should know kind of what we discussed here. That should be enough of what you need to know for ovulation induction, because that is a topic they could ask you as a generalist. Okay. Clomid is generally more used for general population because it is cheaper and easier to obtain. This is from Victoria. Farnaz, if you don't ovulate after one cycle, would you increase the dose? That is correct. So with Clomid, you go from 50 milligrams, 100 milligrams, 150 milligrams. For letrozole, it's 2.5 milligrams, 5 milligrams, 7.5 milligrams, okay? Is it appropriate to also offer OI with HCG plus IUI? Kirby, at this point, I think that is beyond the scope of a generalist, what a generalist will give when you're giving HCG and stuff like that. That's going to be REI stuff. That's beyond ovulation induction, okay? That's my opinion. I think that's a little bit too more. If they're asking you stuff like that on the exam, you ace that section, because that's a little, I wouldn't even know where to start with HCG, to be honest with you. Do we need to know about cycle induction with progesterone, withdrawal bleeding? Withdrawal bleeding is important. I've seen people get asked about Asherman syndrome on this exam and stuff like that. So you need to know what to do with progesterone withdrawal bleedings. Yes. For both drugs, when do we tell them to have intercourse? You have relations every other day for 7 days, beginning 5 days after the last dose of either letrozole or Clomid. I have Adriana asking, do you put them on OCP for 1 full month and induced period? So essentially they are taking the Clomid or Terazole while on menses. Yes, usually what you do is you'll give Provera. That would be like the easier thing to do. I have Jose, if you make it to 150 milligrams, unable to get ovulation, REI. That's what I would do, Jose. You know, because you've done all you can as a generalist. Okay. So, you know, if you guys have questions, keep putting them in the box, but I'm going to go on to the next case. And it's supposed to go to Chihiro, and she's here. Are you there, Chihiro? Says you're self-muted. Hey, Chihiro.
Hi, yes, I'm here.
Turn on, the price is right. Questions? No questions? You're good there, Chihiro?
Yes.
Okay.
Sorry. Sorry,
Any
I just
questions?
joined. I had a long day. Sorry, I just joined.
Hey, man, we all did. What can I tell you? You shouldn't have gone into OB. Should have been a dermatologist, right? Okay, here we go. 15-year-old para-0 who presents with amenorrhea. What is your differential diagnosis?
So for a 15-year-old with amenorrhea, I mean, I would, at this point, I would be worried for primary amenorrhea. And so my differential would be if she's sexually active, it's possible she's pregnant. Or she can have, it depends on what we find on her physical exam, but she could have something like a Müllerian anomaly or Swyer syndrome or Turner syndrome, androgen insensitivity.
So let me ask you this. What is the definition of primary amenorrhea?
Primary amenorrhea is when the patient has not had any menses after age 15 with development of secondary sex characteristics, and 14 or 13 if they don't have any secondary sex characteristics.
Anything else you'd like to add up to your differential?
Those are the ones that come to mind right now.
So how would you evaluate the patient?
So I would get a thorough history and a physical first. And I would ask her if she's currently sexually active and there's a possibility of her being pregnant. I would do a physical exam with the chaperone in the room. And if the patient allows me, I would do a pelvic exam to see if she has a cervix and a uterus.
So let's say she's never been sexually active. Would you do a pelvic exam on her?
I mean, I could, but I understand she's 15 and that can be invasive. And so if she declines, I could alternatively do a pelvic ultrasound, just like an abdominal probe, to see if she has a uterus or not.
So specifically on your physical exam, what are you looking for? I know you said pelvic exam, but anything else you'd be looking at?
So I'd be looking to see if she has something consistent with like an imperforate hymen. That would be like a purplish blue like bulge at the introitus, and that would be another differential. Sorry, I forgot to mention that. And I would see if she has a cervix or not.
Anything else you'd be looking for? Not necessarily pelvic wise.
I mean, I would also look to see if she has any other sex characteristics. At 15, I might also ask if she has any, if she's recently had any significant weight loss, since that can also contribute to amenorrhea. I would also look to see if she has physical exam findings consistent with Turner, such as like a webbed neck and a broad chest. And that would be what I would be evaluating for.
And in regards to secondary sexual characteristics, what specifically are you looking for?
Development of breast buds, development of any axillary hair or pubic hair.
And why is that important?
I mean, I guess, I mean, at the age of 15, regardless of if she has secondary sex characteristics, if she has amenorrhea, that would qualify for diagnosis of primary amenorrhea. But it would be something that I could keep in mind, since if she does have secondary characteristics, it does mean that she has like estrogen in her system.
Okay. So what diagnostic tests would you order and why?
So for me, it would depend on what we find on a physical exam. If the ultrasound shows that she does have a uterus, then I would be concerned for maybe like Turner's or something hypothalamic. So I would get an FSH and an LH. If she does not have a uterus, I would get a karyotype screening to rule out androgen insensitivity or a Mullerian agenesis.
Can you differentiate diagnostically just with lab work, excluding a karyotype, Mullerian agenesis versus androgen sensitivity syndrome?
You can also get a testosterone level. With androgen insensitivity, you would have an elevated testosterone. With Mullerian agenesis, you would not.
Any other diagnostic tests?
That's probably what I would start with. I can't think of any other diagnostic tests right now.
So how would the following results change your differential? FSH, TSH, prolactin normal, HCG negative.
So FSH, TSH, prolactin is normal. Then I wouldn't be concerned for like Kalman syndrome or Turner syndrome. So those would be off my differential.
Why would they be off your differential?
So for Kalman's and FSH would be low. For Turner's, your FSH would be elevated. And then if her HCG is negative, then pregnancy is also not in the differential.
Anything else that you would remove for your differential?
I mean, also like female athletes triad. That would also be not in my differential because for that her FSH would be low.
Anything else?
No, that's my answer at this time.
Okay. All right. Would you order any additional testing?
I mean, at this point, I would still want to get a karyotype. And depending on that, I would also want to get a testosterone level as well.
Anything else?
I can't think of any other tests right now.
Okay. So what is androgen insensitivity syndrome and its management?
Androgen insensitivity syndrome is when the patient's karyotype is XY, but the androgen receptor, there's a mutation in the androgen receptor, and so even though there's elevated levels of testosterone, the cells don't respond to that. So phenotypically, the patient appears as a female. And they also present with primary amenorrhea as well. Management would be, I would be co-managing this patient with a reproductive endocrinologist. But to my knowledge, we would allow the patient to go through puberty, and then after puberty, we would have to remove their gonads since they are at increased risk for dysderminoma.
So why does androgen sensitivity syndrome occur?
There's a mutation, I think, in the SRY gene. And so the receptor for the androgen is mutated. And so even if you have elevated level of testosterone, the cells don't respond to that. So you end up with a phenotypically female phenotype.
What else would you do in the patient's management? So you said you would take out the gonads.
Yes.
After development. Anything else?
Yes. I think there's I know there's something else we have to do, but I can't recall at this time.
Can this individual have sexual relations?
Yes, I mean, they can. They just can't have children because they do not have a uterus.
So they have a vagina?
Yes.
All righty. What'd you think? Why are you laughing?
Sorry, it's just I know there's something with androgen insensitivity in terms of management, but other than gonadectomy, I didn't know how to manage.
No, this is not an easy topic. I think you did well. Yep. So let me just, for everybody on the call. So primary amenorrhea is lack of menses by 13 with no breast development, lack of menses by 15 with breast development. So it's very important to figure out if the patient has breasts, also a uterus, because that will kind of differentiate what the patient has. So for everybody on the call, 46XX, obstructed outflow tract. They will have a uterus. Mullerian agenesis, they have no uterus or rudimentary uterus. Kalman syndrome, they have a uterus with no breast development. Functional hypothalamic amenorrhea, they will have a uterus. 46XY, androgen insensitivity syndrome, they will have no uterus. A 5-alpha reductase deficiency, no uterus. Swyer syndrome, believe it or not, has a uterus, because that's the one with the SRY gene mutation. You need the SRY gene in order to have development of the Wolffian structures. But because you don't have that, you end up genotypically being male, but phenotypically being female. And then Turner's is 45XO. Androgen sensitivity syndrome is an X-linked mutation. Okay, so female siblings may have the same disorder. So you treat with psychological counseling. The presence of a Y chromosome material places patient at a risk of gonadal tumors, gonadoblastoma, dysgerminoma. You need to undergo gonadectomy after breast development is complete, and after surgical removal of the testes, estrogen therapy is recommended to maintain secondary sexual characteristics. They usually have a short vaginal pouch, which can be lengthened by the use of vaginal dilators or surgical creation of a neovagina, because the testosterone doesn't click the Wolffian ducts to develop. Okay. No, but I thought you did well, Chihiro. It's not an easy topic. Okay.
Yeah, thank you.
Sound like a plan. I thought you did well. Very good. I mean, very nicely done. I can't add more to it. I would have pissed in my pants if I gotten this question. That's a hard question. I got some questions here. Let me see here. Hold on. I have, how do we know when we are comfortable starting someone on ovulation induction? I mean, Ashley, everybody has different viewpoints. When you talk to her on REI, you could tell a patient to lose weight. She doesn't lose weight. I've asked REIs this, and they're like, yeah, we just give them, we help them get pregnant. You know, because they don't have to deliver them, we do. And then we end up with, you know, the BMI of 70, and then what do? Because we're bad doctors. This patient should never have gotten pregnant. For any additional testing, would you order secondary amenorrhea tests since you didn't specify? Yeah, you can do that, 100%, Bobby. Yes, you can do, your prolactin, TSH, and all that good stuff. Yes, I agree with you, Bobby. Definitely. So I don't see any other questions. So thank you so much, Chihiro. I thought you did great. But people keep putting in your questions because we'll get those answered. I am going to Elizabeth. You're next on the hot seat here. Are you there, Elizabeth?
Yes, I am.
Subspecialist or generalist?
A subspecialist. I'm a urogyn as well.
Urogyn, you're going to do great on the next one.
Oh.
It has nothing to do with urogyn. That's why I try to aim for. Guys, if you have questions, just keep putting them in your question box and we'll answer them. Okay, I just want to keep people on the hot seat. So 22-year-old para 0 presents to the clinic with concerns for pregnancy. How would you evaluate the patient?
I would evaluate the patient by taking a thorough history, trying to see if she has, when her last period was, try to see if she's had any bleeding, see if her periods were regular, when the last time she had sexual intercourse was, if she desires to keep the pregnancy or what her fertility or her pregnancy desires are. I would also ask her about her past medical history, her past surgery history, any medications that she takes, as well as the family history. And then I would proceed with a physical exam, ultimately doing a urine pregnancy test, as well as likely an ultrasound, depending on the results of the urine pregnancy test.
So if the pregnancy test is negative, would you do an ultrasound?
No, not at that. No, not at that time.
So what diagnostic tests would you order and why? I know you gave me a little bit more of that answer, but anything else?
I would probably also go ahead and, during the evaluation, do a pelvic exam to see if she had any abnormal discharge or anything like that, if she had a cause for her bleeding or why she had concerns for the pregnancy in the first place. And I could always do a vaginized panel if I saw any abnormal discharge, any STI testing. And again, the urine pregnancy test and a possible ultrasound.
But the ultrasound only if the pregnancy test was positive? Or did I misunderstand you?
My plan would only be to do the ultrasound if the pregnancy is positive, if the urine is positive.
HCG was positive, okay. So let's say the patient had unprotected relations 4 days ago. How would you counsel the patient?
Again, I would, in terms of her sexual history, ask her if it was consensual, ask her if it was a partner that she knew, if she was concerned about any STIs. Again, if she was concerned, so it says that she had unprotected relations. So if she was or was not interested in emergency contraception, we could discuss emergency contraception at this time, and obtain that history first before moving forward.
So let me ask you, let's say she is interested in emergency contraception. Is there any specific testing that has to be performed before that is offered?
To be quite honest, I don't know.
So let me ask you this. Do you have to do an HCG?
No, it does not. She does not need an HCG if she wants emergency contraception.
So what if she's pregnant? And I'm talking about medical emergency contraception, not an IUD.
Sorry, I guess I would say that you would want to rule out if she was pregnant prior to providing her emergency contraception. Well,
so I made you change your answer from no to yes. Am I correct?
Correct. But sorry, I ultimately think that she would not need to have, sorry, I'm just going to take the question from the beginning. I ultimately don't believe that she would need a urine pregnancy test prior to receiving emergency contraception, but we would have to monitor her closely to see if she does become pregnant.
Because she took the emergency contraception? Are you saying the emergency, I'm talking about the oral emergency contraception, is that going to be detrimental if she became pregnant?
I would ultimately have to look that up. I'm not sure.
So you're saying you don't have to do an HCG. However, there might be an issue if she does get pregnant after taking this medication. Am I correct with what you're telling me?
I believe so.
So please go into detail on the different emergency contraception options that are available.
Yes. So the first that comes to mind is an intrauterine device, specifically the copper IUD, to be used for emergency contraception, and then other medications like oral medications would be ulipristal acetate, as well as I believe you can use high dose of combined oral contraceptive pills, and those are the medications that come to mind.
Okay, so you said you would do the Paragard, correct?
Correct.
In what time frame is it beneficial?
She can have the IUD placed within 5 days.
And then you said, go ahead.
Within 5 days of the unprotected intercourse.
And then you said the ulipristal. What's the time frame there?
I believe ulipristal would require to be taken within 3 days of unprotected intercourse.
What is ulipristal?
It's a selective progestin receptor modulator.
And what is the mechanism of action?
I believe it would block progesterone, but I would have to look up exactly how it would work.
And then you said the birth control pill, correct?
Yes.
Anything else you could offer?
Nothing that's coming to mind right now.
Which is the most effective?
I believe the copper IUD is most effective.
Followed by?
Followed by the ulipristal.
Okay, and then the birth control, correct?
Correct.
Birth control pill. Now, how would you advise the patient to follow up after being given the oral emergency contraception?
After being given the oral contraception, I would likely recommend her to be followed up within 2 to 4 weeks to see to see if she had any side effects from the medication, or if she felt like she had any prodromal symptoms of pregnancy, like nausea or breast tenderness or things of that nature.
So when would you see her again? I'm sorry?
In 2 to 4 weeks.
2 to 4 weeks. Okay. So are there any contraindications to oral emergency contraception use?
I would say a contraindication would be if she's ever taken that medication before and has a known hypersensitivity. If sometimes I know that other than that, nothing else is coming to mind.
So let me give you an example. Let's say the patient has breast cancer that's progesterone positive and estrogen positive. Would that be a contraindication to emergency contraception use?
I would say no, it would not be, because it should be an anti-progestin for the oral.
But let's say she takes the birth control pill. You said there's that formulation of birth control.
She would be at increased risk of thromboembolism. So I would probably strongly counsel her on the other
So let me ask you this. So if somebody has a history of a VTE in her history, she is not a candidate for oral emergency contraception?
I would probably recommend against the combined oral contraceptive pill if she has a history of a VTE as well.
Okay. Any other contraindication?
Nothing that comes to mind right now.
Okay. All right, what'd you think?
Oh, so painful. I need to review emergency contraception.
We're gonna go over it right now.
Great.
You do not require any testing. That's why
Okay.
you can take it over the counter, because you missed one, a big one, the one that started it all. Because in the old days, they used to do the combined birth control, but now there's other medications. So you do not require, for everybody on the call, you do not require HCG, an exam. Emergency contraception has no adverse effect to an existing pregnancy. Okay? So the most effective is Paragard at 120 hours, 5 days. It is 0.19% failure rate. Then comes the Mirena or Liletta, 52 milligrams of levonorgestrel IUD, also 120 hours, 5 days. That's 0.3% failure rate. Olipristal, the Ella, is a selective progesterone receptor modulator, 30 milligrams PO times 1, also 120 hours, 5 days. It delays or inhibits ovulation. 1.4% failure rate. Then the Plan B, that's the one you forgot. Plan
Right.
B is over the counter. It has no estrogen in it. It's levonorgestrel, 1.5 milligrams PO times 1, 72 hours, 3 days. Off-label use is 120 hours or 5 days. It also delays or inhibits ovulation, 3% failure rate. You would follow up the patient. No period in 3 weeks. You perform an HCG, and please counsel her on her contraceptive options. Are there any concerns or contraindications to oral emergency contraception use? Almost everyone is a candidate for oral emergency contraception use. Medications that could induce the cytochrome P453A hepatic enzyme could theoretically reduce oral emergency contraception efficacy, such as rifampin. The packaging for Plan B states that the use of Cystiva, which is an HIV medication treatment, rifampin, phenytoin, carbamazine, may reduce its efficacy. BMI of greater than 30 may decrease the effectiveness of Plan B up to a 6% failure rate. Studies have been contradictory about the effectiveness in doubling the dose. Olipristal's effectiveness does not appear to be affected by BMI. It has a 2.6% failure rate. For patients with malabsorptive bariatric procedures, Plan B's absorption is most likely compromised. Data for olipristal is not available. Thus, the most effective emergency contraception method in this group is the IUD. So that's emergency contraception in a nutshell.
I wish I had before this.
Say again?
I wish I had that quick nutshell before this. Yes.
But that's the nutshell. So I have some questions here. Hold on, let me take a look. Hold on a second here, looking. So Jennifer says, no pregnancy test for just PO, but for IUD, correct. I would for an IUD, because if she's pregnant, you're not going to stick an IUD in, Jennifer. So 52, so the Mirena IUD is also approved now for emergency as well. That is correct. Not FDA approved, neither is the Paragard, but it is. The Mirena is a 0.3% failure rate, but it has to be the 52 milligrams. So Liletta or Paragard, it cannot be the Kylena. Okay, it cannot be the less than 52 milligrams. Okay, or the Skyla. Okay, it has to be 52 milligrams. For the IUD, would you have to do a pregnancy test then? It wouldn't be positive. It's just 4 days ago. Correct. Because yeah. So if she's pregnant now, you would show it. You do not put the IUD. So there's no contraindication per se, but rather better option for obese patients compared for other options. Correct, Jose. You just could have a failure. And I don't know if you want that. Okay. You know, you got to just, you know, educate the patient on that it could fail. You know, yeah. Okay. So questions, Elizabeth?
Nope, just got to keep studying.
Yeah, but you're a Urogyne, so you should be an expert on all the Urogyne stuff. So I have a question here. Do you need a GC chlamydia before the IUD insertion? That's old school thinking, Emily. It is, you could still put the IUD in without those results. I do know people do those cultures. If they come back positive, they will contact the patient and treat them at that point. And maybe monitor the patient a little bit more closely, give her strict precautions, because there's always that possibility of PID. She did have instrumentation, but it's not an indication anymore. You can literally, if a patient says she wants an IUD, you can put it, as long as she's not pregnant, you could put it in. But when I trained, you had to have a GC and chlamydia that was negative. It would be like this long, prolonged thing in order to get the patient to put an IUD in. Now the recommendation is you just put it in if the patient wants it that same day, and if it's available. Sometimes you have to get that prior off from insurance. Okay. Any other questions here on all the stuff that we talked about? Because we are over, we got a lot of people on the hot seat here. Everybody that was supposed to go, the first group went, so that's why I didn't go to the second group. So if anybody was not on the call, but everybody was on the call. Any other questions? Oh, okay, I see here a question. Can you please go over modified glucose screening 4 points versus jelly beans for patients with no bariatric surgery? Thank you. I mean, I know there's some things in regards to jelly beans, eating Snickers, and I have no idea. I think the easiest thing to do is just to do a glucose log for the next 2 weeks for the patient. So she eats whatever she eats at home. Do your fasting 1 hour or 2 hour postprandials, and you follow it as a diabetic. So fasting's greater than 95, 1 hour greater than 140, 2 hour greater than 120, she fails. If the average is higher, I mean, you'll look at the numbers and you'll know, yeah, she's a diabetic. To tell you about the jelly bean stuff and all that, I know it exists. There's some protocol. I don't know it off the top of my head. For me, it's just easier to tell patients, just get your glucose, just do a glucose log and we'll monitor you that way. Hemoglobin A1C will not help you, because that's usually going to tell you if she's more pregestational. Okay, I'm talking about gestational. That's a little bit different. She might be pregestational just because of that BMI of 50, that particular case. So I think it's just easier just to do the glucose monitoring for the next 2 weeks. I have, how do you dose OCPs for emergency contraception? There used to be an old, there's called the Yuzipe, Y-U-Z-E, Y-U-Z-P-E-E, Yuzipe. That individual, I think it was a guy, he's the one who came up with all this. And it was first started with the birth control pills. So depending on the birth control pill that you were on, you could take a certain number of pills. So there used to be this little like card that if it was, I can't think of a brand right now, but this particular brand of birth control pill, you would take 4 pills every like 8 hours or whatever the case may be. The negative with that is the patient would get very, very nauseous from that. So that then they started doing more studies and they realized it was the progesterone. So the plan B is only progesterone. Ulipristal, there's no estrogen in either of those medications. So realistically, if it's, I mean, I know plan B is expensive. It's, I think, at least $75. But that is over the counter. But you will tolerate it much better than you would the birth control pill. So there is these cards. You can, I mean, I'm sure you could look it up online right now. You said emergency contraception for birth control. Some old chart will pop up and tell you how much of each pill to take. And sometimes you would have to take like 5 pills at a time. So a lot of medication. So Shakira, that exists, but there are other options. And actually, when you read up to date, it doesn't bring that up. Does not bring up. I don't recall reading about the birth control pills being, 5 pills at a time. So the stuff that we discussed, that should be accepted. So I'm being asked by Nicole, You did some prompting for the answers to help direct the conversation. Was this for teaching webinar purposes, or will the examiners do prompting on the test day? I did it more for teaching a webinar. If I have to be honest, it depends on your examiner. I think for the most part, they're not going to prompt you, but they feel you're doing a good job. Maybe they realize you forgot to say something, like she had forgotten the semen analysis for that one case for infertility workup. She knew everything else. So I just want, and she realized, and she said semen analysis. But it depends on your examiner, but I would anticipate you would get no coaching whatsoever. I mean, this is getting taped and we have other people on the call. So we want you guys to get a good experience and learn as much as you can, but be able to be on the hot seat. We do have the individuals that are on the hot seat, but then we have everybody else that's listening. So I do want it to be an educational forum for those listening as well. Okay, so Nicole, I would suspect no, maybe you get lucky and your examiners will, but anticipate that they will not. There'll be no feedback whatsoever. Okay. So if anybody else has any other questions, please put them in the question box. But I think everybody did a fabulous job this evening. I mean, these were some hard topics, and we had two subspecialists, so I think they did very, very well. I have another question here. Can we say that past 5 days, that's a contraindication for emergency contraception, and at that point, the management would be for TOP should a pregnancy be confirmed? I mean, can you give an emergency contraception? I guess you could, but you're beyond off-label use. It's probably not going to work. Realistically, with an IUD, past 5 days is the patient, her pregnancy test would probably still be negative, possibly. So I think if her HCG is still negative, you could still put it in. But would it be as effective? Can you have an implantation? It's possible. That's a tough one. Jose, I mean, you could still give it, but anticipate that's not going to work. It's not going to harm anything. But you don't want the patient to have a false hope that this is going to be the end all be all when she comes in 7 days after the unprotected relations. You know what I'm saying? So that's a tough one. I think you could still put the IUD. I don't know how beneficial, because if you did a pregnancy test, it's going to be negative because probably it's not going to show anything, but is it going to be effective? I don't know if that helps you, Jose. That I can't answer that question. The IUD you probably can still place. Hopefully it's still be beneficial in not getting her pregnant, but I can't guarantee that. So hopefully that helps. Any other questions? I know some people would like to do private chats and stuff like that. So I will stay on the line for a couple of minutes after the end of the webinar to see if anybody has any other questions, to do a private chat. They don't feel comfortable kind of having it in this open forum. But I appreciate everybody that participated in the hot seat. Again, we are adding a Thursday webinar for the month of September. So every Thursday, there will be a case list defense webinar. So there will be one tomorrow. And we'll be doing the same thing, being on the hot seat. Please make sure that you have submitted your case list to the office so it could be downloaded to the cloud. If not, we could always ask you topics, or we can use somebody else's case list in order to ask you questions. We just want you to be on that hot seat and get that experience. So what we're trying to do is getting 6 people on the hot seat for each evening. And then we have a running tally of those individuals. So we've met our 6 today, so we did good. Thank you. And hopefully we could do the same for all the other days that we have for the webinars. Again, I'll stay on the call for a couple of minutes. If anybody wants to do a private chat, if anybody has any recommendations to make these better, any topics they'd like to know more about.